Opiate withdrawal. Just quickly about opiate withdrawal. So these are people who, who chronically use opiates. Usually it's patients who use, heroin, people who use fentanyl, or people who have prescription opiates. Okay. Now, these people who have prescribed opiates for a legitimate reason, when they are admitted, you should continue their doses. Continue their pain medications. Okay. While people who, fentanyl, Versed, they are they're at risk of withdrawal. Now, how does opiate withdrawal look like? Opiate withdrawal looks like, it's similar to alcohol withdrawal. They'll have agitation, they'll have headaches, but the extra stuff for opiate withdrawal is you get GI symptoms. Specifically, you get diarrhea. And then obviously you get pain, because their pain response is kind of is hyperactive or hypersensitive. And then, finally you get generalized symptoms, skin manifestations, neuropathic pains, these things. Now, just like alcohol withdrawal, the withdrawal symptoms of opiates can start as soon as an hour after stopping, depending on how much they use. Okay, so if this is the time, and then somebody is using heroin, I don't know, every day, and then for some reason here they stop, okay, then the symptoms of withdrawal might start right away. And do you know when do they go away, the symptoms of withdrawal? What do you think? So it's tough to kind of figure out when they actually go away, but some people say never. People will always have these kind of symptoms of opiate withdrawal unless you treat them. And this is why these people, you will see them, they will be on chronic therapy with something, with usually a partial agonist or a full agonist, depends, okay? So that's why when you manage these people, you're not going to manage them as an outpatient, but these people in the outpatient setting, they can either be on methadone, which is an agonist, or they can be on buprenorphine, which is this partial agonist, okay? No one uses this word, buprenorphine, it's usually called Suboxone, because it's mixed with naloxone, okay? So you might see somebody who shows up to you with these medications, but we're not talking about that. We're talking about somebody who actually shows up, who uses heroin every day and now has infective endocarditis, and he's in the hospital, not using heroin anymore. And now they're gonna have the withdrawals, they're gonna have the GI symptoms and everything, okay? So remember, the opiate withdrawal is never fatal, okay? Which means when you're treating those people, you don't need to do the standing, you don't need to do the PRNs, everything. So you wanna treat them PRN if needed. And some institutes will have you able to give them methadone as an inpatient to start the whole, to just start the whole ball rolling for them to be an outpatient. But for example, where I practice, in some states, in Massachusetts, you can't just prescribe methadone. Me as a resident or even my attending couldn't. You have to be a specialist, or you have to attend some seminars, or you have to have a workshop or something to be able to even prescribe methadone. So you can't just give them methadone in the hospital. And so instead you can give them opiates, okay? So what usually happens is you can give them, morphine, and you don't want to give them massive doses. You can give 1 milligram of morphine IV, And usually this, they don't feel it, because they're used to heroin, which is, I don't know, 20 to 30 times more potent than morphine. And so what they're going to ask for hydromorphone. Hydromorphone is, again, the trade name for it that you should know is Dilaudid. And this is the medication they actually like, because it's almost 20 times more potent than morphine. And even if you give like 0.5 milligram IV, it kind of, it feels good because it gets that rush of almost like heroin that they kind of feel. Okay, so what I always suggest is never give it push. Instead, you can either dilute it in like 250 cc of normal saline, or you can give it subcutaneously. It will kind of prevent the symptoms of opiate withdrawal. Again, when you think about it, the symptoms of opiate withdrawal, they really never go away. So to what end are you treating this? You're really just kind of, keeping everybody quiet, everything kind of calm in the hospital. But eventually, I think they will need methadone. Okay. The other thing you should know is if patient is on methadone and you want to continue it, then you can continue, but you have to confirm the last dose, and you want to confirm the actual dosage, how much methadone they were on. And you can't just assume, you can't just take their word, oh, I'm on 100 milligrams of methadone. No, you have to actually call, or whatever hospital, whatever institute, or whatever doctor is giving them the methadone, you can confirm that. Or so you either call their prescriber, or you can call their pharmacy. Or, if you're practicing in New York, in Massachusetts, or in some of these places where they have a lot of incidents of like these things, they actually create there's a website. There's a government or like a state website that you enter the patient information, and it gives you all the benzos and narcotics that they've been prescribed. And so you will get the actual prescription, and it will show you exactly how much they're getting or supposed to get. Okay, so I think usually you can just call, and then when you call, you can't just get a verbal confirmation. You actually need to get the document itself. So they need to either fax it or something, and you need to put it in the patient's chart, physical chart, in order for pharmacy to even release the methadone. Okay.